It has been 10 years since the development of the double balloon endoscope. In 2013, a new model of the double balloon endoscope, EN580T, became available. This new model features a high-resolution Super CCD with close focus ability, which enables more detailed diagnosis, and also features a 3.2 mm diameter forceps channel, which enables more efficient treatment. While the double balloon endoscope allows diseases of the small intestine to be diagnosed and treated accurately and in a minimally invasive manner, it is essential to use the endoscope properly to realize its full potential. That is why we have produced this video, which demonstrates the insertion of the double balloon endoscope in an actual clinical setting. In order to insert the endoscope smoothly, it is important to keep the shape of the endoscope shaft as simple as possible and to advance the tip of the endoscope efficiently with minimal force. I hope you find this video helpful as a guide to the safe and effective use of the double balloon endoscope.
この患者さんは
This patient was hospitalized at another hospital 6 weeks ago for small intestinal bleeding and underwent an angiographic embolization to control the bleeding. We are conducting an enteroscopy today to examine the small bowel for an ischemic stenosis thought to be the result of his previous embolization therapy. Double balloon enteroscopy, or DBE, will be performed from an oral approach. Let's get started.
For the initial insertion, the overtube is pulled back to the end of the endoscope and the endoscope tip inserted in the same way you would normally insert an upper gastrointestinal endoscope. Once the endoscope enters the stomach, we start to advance the overtube. We are now inside the stomach.
Liquid pooled in the stomach could cause aspiration later, so suction as much liquid as possible. We are inside the stomach, and the balloon at the end of the overtube is at the mouth. Sufficiently lubricate the overtube with gel and then slowly slide it forward over the endoscope.
Ensure there is no resistance when you insert the overtube and apply enough lubricant so that the tube can be inserted gently. There is a thick white linear mark on the endoscope. If you insert the overtube up to the point where this white mark is visible, the balloon at the tip of the overtube will be right next to the balloon at the end of the endoscope. Be careful not to slide the overtube beyond the thick white line, as this may dislodge the balloon on the end of the endoscope. Once beyond the stomach, add water between the overtube and endoscope from time to time to make it glide easier. From here, the endoscopist operates the endoscope with an assistant holding down the overtube. The balloon is not yet inflated yet because the overtube is still inside the stomach.
We are now close to the pylorus. With the endoscope as it is, we advance the overtube again. Okay, all right. It's better if there is as little gas in the stomach as possible, so I'm going to suction a little before we go in.
It's CO2 insufflation, isn't it?
Yes, that's right. But even though it is CO2, we are going to be insufflating as little as possible as we go in.
The secret to minimizing gas insufflation is using a hood on the distal end of the endoscope and using small amounts of water in place of gas. This will enable you to secure a field of view with minimal gas.
そういうことで早期を最小限に抑えることができます。今12
Now we're just about to intubate the duodenum.
Yes.
This is the duodenal bulb here.
From the duodenal bulb to the second part, we are going to torque slightly to the right as we enter in the same way as a normal upper GI endoscope. Then as you reach the inferior duodenal angle, torque very slightly to the left as you go in. At the ligament of Treitz, I will torque very slightly to the right as I enter. I have used left-right dials as well to advance the endoscope tip and past the ligament of Treitz by using a right torque. Then advance the endoscope slightly further.
You can effectively advance the end of the endoscope by swinging the tip using the endoscope dials or right and left torque of the shaft. When the endoscope end is sufficiently advanced, inflate the endoscope balloon so that it is grasping the intestinal wall as you advance the overtube.
All right, advance the overtube. Apply lubricant gel as needed, okay?
If you feel resistance passing the overtube here, stop partway through, adjust the shape of the endoscope, and pass it again so that the overtube can be inserted smoothly. If you feel any resistance, tell me. You can continue to advance it as long as it's moving smoothly. Advance the overtube up to the point where you can see the white mark here, okay? Now the end of the overtube has come up right next to the endoscope tip, so we will inflate both balloons.
At this point, the distal end of the endoscope has passed the ligament of Treitz, but the overtube may not have passed the ligament of Treitz. So we will begin the next part of the process without pulling back on the overtube to pleat bowel that much. Remove your hands from it a little. Pull it just enough to remove the slack.
Inside the stomach, the endoscope is still in the shape of a curve and has not yet made a straight line. Can we get a quick look at that fluoroscopic image? Yes, you can see it in the shape of a curve in the stomach. Okay. There is no need for fluoroscopy in the actual endoscope insertion itself. This is just to show you what kind of shape the endoscope is in.
After the endoscope balloon is deflated, I start advancing the endoscope again further into the intestine.
Try to use the minimum insertion force necessary, transmitting it effectively to the endoscope tip to advance the endoscope as efficiently as you can. To do so, you want to avoid pushing the endoscope when the endoscope angle is fully flexed. Swinging or jiggling the endoscope tip using the endoscope dials or right and left torque of the shaft may help the distal end advance smoothly.
Please make it 20 centimeters. The insertion distance for the first stroke was 20 centimeters.
Try to picture the direction of the lumen that you are advancing into and insert the endoscope, jiggling its distal end. Moving the endoscope in this way will push the distal end in with the least amount of force needed. Simply jiggling will help the distal end advance smoothly.
Okay, the second stroke was 30 centimeters. All right, insert the overtube now. Here is the endoscope being carried by peristalsis. By inflating the balloon on the end of the endoscope, peristalsis will help the endoscope move forward.
This is why, as a rule, we do not use an anticholinergic agent for an oral DBE insertion.
Okay, then we shorten the loop here. I'll show you the fluoroscopic image for reference. As you get used to the procedure, fluoroscopy will no longer be necessary. If you torque the scope 180 degrees to the right, when you do the shortening operation, you can remove the loop smoothly.
Once you become comfortable with this procedure, you will no longer have to use fluoroscopy for reference because you will be able to proceed by feel. The key to safe and effective insertion in DBE is to advance the endoscope end with as little force as possible. To do so, it is extremely important to adjust the shape of the endoscope. As long as a good shape is retained, the endoscope distal end can be inserted with minimal force by jiggling.
All right, advance the overtube.
The peristalsis is working effectively.
Yes, that's right.
When the endoscope shaft is advanced without the distal end moving forward, a complicated loop is formed and it will create a more disadvantageous situation for the next insertion step. In other words, by advancing the distal end of the endoscope without pushing the shaft too much, you can retain a simpler shape.
When shortening without fluoroscopy, add some torquing movement to the left and right like this. When you see direct responses on the screen and you don't feel any resistance, you can assume that the endoscope is sufficiently shortened and unnecessary loops have been eliminated.
During the shortening operation, it is important to arrange the shape as simply as possible to make the next step easier. I want to stress that you can't simply pull it.
Ultimately, if the endoscope is straightened out and the lumen of the small intestine is visible, the next insertion will be easier.
The pressure of the DBE balloon is designed for extremely low pressures, 45 mm Hg, which significantly limits the gripping force. The key to insertion of DBE is that the insertion goes well under conditions of such low gripping force. We do not want to simply push the endoscope in regardless of the form. Rather, we want to adjust the shape of the intestine that would enable easier insertion and use a balloon to retain this adjusted shape. Also, ideally we want to use the minimum insertion force required. Thinking about the endoscope in this way will help perform a safe and effective insertion.
30 centimeters. All right, advance the overtube.
If you always try to maintain a natural shape of the endoscope while inserting, intestinal loops will naturally form the shape of concentric circles. One of the important key points of insertion is to make the loops as large and round as possible. Pushing with the endoscope tip fully bent when advancing may result in small and complicated loops. It is best to enter using the least number of loops necessary that are composed of large arcs and as close to straight lines as possible.
Yes. Some food residue has appeared.
Luckily, the intestinal fluid is relatively clean.
Yes. Well, it is at least a clearable residue.
This is intestinal stasis that accompanies stenosis, or intestinal fluid pull due to partial mechanical obstruction. Well, as long as you adjust the small intestine to form nice round concentric circles, provided that there is no adhesion, the endoscope insertion will not be so difficult. You'll be able to do so smoothly. There are common tips for endoscopic techniques. For a safe and effective insertion, the basic idea is to maintain a simple and easy shape of the endoscope. Do not make things complicated. As you become used to the technique, you will be able to start shortening before the overtube balloon inflates completely. Since the endoscope balloon is already gripping the intestinal tract, there is no need to wait until the overtube balloon is fully inflated before starting shortening. The overtube balloon will be fully inflated to grip the intestine together part-way through the shortening. However, until you become used to balloon-assisted endoscopy, it is better to wait until the balloon is fully inflated.
Now that I have pulled a little too much, the balloon's internal pressure has risen and the alarm has gone off. Please secure it here.
Now he deflated the balloon on the endoscope tip and continues inserting the endoscope.
The lumen is larger now. We must be near the area that is causing stenosis.
I think we've come close.
It is really larger. We have not insufflated at all since we started, but there is gas trapped in the intestinal tract due to partial mechanical obstruction, so I will use suction as I advance. All right, advance the overtube. I said this earlier, but when you pull the overtube, grasp and hold both the endoscope and overtube together and torque to the left and right as you pull back. When you do this, feel the resistance and watch on the monitor. When you pull, try to find a kind of free feeling. If the image on the monitor tracks this torquing motion without any time lag, you know that you have removed any unnecessary loops. Okay, please secure this. Pull it to at least that point, and as the feeling of resistance increases, you can assume that you should not pull it any further.
So it is not simply a matter of just pulling during shortening. It is important to understand that you are adjusting the intestine in such a way that will make the next insertion easier. If the intestinal tract is adjusted in such a way that the endoscope movement becomes effortless, that is the minimum required pulling distance, and then you perform fine-tuning by the feeling of resistance.
いうことになりますね。
Until you are used to it, you may try to push the endoscope in, but if you force it in DBE, the overtube will slip out, because wall gripping by the overtube balloon is not very strong. This will result in an inefficient insertion. As you become used to the procedure, you will realize that it doesn't require much strength. If you adjust the shape and insert it smoothly, the endoscope insertion will require almost no strength. There is no need to apply excessive force.
20 centimeters. No, make it 30 centimeters.
The villi look a little edematous. Yes, the villi look like they are a little swollen.
Hold the overtube.
We may have come close to where the congestion is.
Yes, that's right.
There's an ulcer. That swelling must have been a swelling of the villi near the ulcer.
It may be an ulcer caused by ischemia.
We have now arrived at the lesion site. It has been a very smooth insertion up to this point, and as long as you always try to insert in this way, a safe enteroscopy is possible.
All right, advance the overtube a little bit. About 5 centimeters from the last location. There's the lesion.
That's an extremely shallow lesion, isn't it?
Let me take a look at the fluoroscopic image.
The intestinal tract is forming nice concentric circles. The fluoroscope moves a bit, so that it's like this.
It is difficult to change the position of the distal end, so it might be hard to get a closer view of the stenosis. Okay, hold this. I will now spray the indigo carmine. Okay, open the clip. Okay, close. One more?
Now we have to prepare to mark it with black ink too. We're ready to do it, are we? Okay.
If we can, we should put the patient in the supine position and mark the location on the side where water does not pool.
Yes, that's right, on the abdominal side, so that it is easy to see during operation. So that it will be on the anterior wall side.
Okay, open. Okay, close. That was a little loose. Is that all right? Yes, let's put in supine. The reason for using two marking clips is that if we only use one clip, it is hard to determine from an X-ray whether the clip is where we attached it or whether it has fallen off. If we attach two clips together, we can be more certain that the two clips have stayed where we attached them initially.
When marking with ink, we use an injection needle. The walls of the small intestine are very thin, so it is not always easy to inject into the submucosal layer. First, we inject saline to clearly identify the submucosa before injecting the ink. So this contains saline.
Okay, needle out, please. Flush the needle slowly to let it drip.
This needle for injecting ink is made with an extremely narrow diameter catheter and has no dead space, so even if we change to ink, the ink reaches the distal end relatively quickly. It's leaking a little, isn't it? Yes, it's going into the submucosa.
Okay, stop. Okay.
Apply a little bit of negative pressure as you pull. The needle is put away now. By this procedure, you can mark with ink without hindering the view of the endoscope.
Next, let's move to the fluoroscopy. Position the patient face up and align the position.
When you are observing a stenosis under fluoroscopy, you can see a clear image of the stenosis site because the balloon on the end of the endoscope blocks the reverse flow of the contrast media. Now we will use a water-soluble gastrointestinal contrast media and sodium amidotrizoate meglumine liquid diluted 2:1 to create the image.
The patient is a 58-year-old man whose chief complaints are a sense of abdomen distension and constipation. Our previous physician conducted an upper and lower endoscopy that resulted in no significant findings, and abdominal CT that showed slight thickening in the walls of the small intestine and retention of intestinal fluid. A capsule endoscopy was conducted, but the capsule endoscope was retained and only came out 3 weeks later. A slightly increased CRP 1.8 combined with the CT findings just mentioned suggests Crohn's disease. Today we will conduct a DBE through the transanal route.
This patient has not been treated at all.
No, he hasn't been treated nor diagnosed.
This is CO2 insufflation, isn't it? I'm turning it on.
Before we start, I will apply anesthesia gel to the patient's anus and begin.
For transanal insertion, the overtube is also positioned at the back end of the endoscope. Then begin insertion in the same way as an endoscope is inserted for a colonoscopy.
Okay. I am applying the anesthesia gel now. I am inserting my finger a little. Let's get started. I am now flushing with an anti-foaming agent.
He's not using the overtube yet for the initial insertion, so while he is holding the endoscope, the procedure is still almost identical to a colonoscopy insertion.
Because our method is to use as little gas as possible, we attach a very short hood on the end of the endoscope. We use the water supply function on the endoscope and add water bit by bit as we enter. When you can see the air and water on the screen, the bubbles hinder the view, but if you replace all the air with water, you can obtain a stable view.
Are you using an anticholinergic agent right now?
Not yet.
We are using a combination of pethidine hydrochloride and midazolam. If a spasm occurs, we will use an intravenous anticholinergic agent as necessary. In the case of DBE, the endoscope is equipped with an overtube, and the endoscope can be advanced approximately 55 centimeters until the overtube tip is at the anus. Insert the 55 centimeter endoscope portion until it almost reaches the vicinity of the sigmoid descending colon junction. If you go in straight, the endoscope may advance as far as the splenic flexure. The insertion method is the same as normal colonoscopy up to this point.
So now we inflate the balloon on the end of the endoscope and advance the overtube. Apply plenty of gel and begin advancing.
Now the endoscope enters the sigmoid colon with a slight curve. Can we say that the endoscope end is near the sigmoid descending colon junction right now?
Yes, that's right.
Since the curve is not sharp, it is possible to advance the overtube while maintaining the curve. The overtube is already advanced to the distal end of the endoscope. When the white mark on the endoscope becomes visible, that's when the balloon at the tip of the overtube is next to the balloon at the tip of the endoscope. In other words, both balloons are next to each other. It doesn't mean that you have to shorten it to straighten it up, does it?
That's true. It's not necessary at this stage.
Retaining a natural curve is okay, as the large intestine itself has a certain degree of resilience. If you straighten the endoscope here, the balloons may slip back to make the curve again. Yes, here.
Now deflate the balloon on the end of the endoscope and begin advancing.
If the balloon is held while a natural curve remains in the sigmoid colon, you can pass the sigmoid descending colon junction easily because the sigmoid colon retains its shape. Without forcing the large intestine into an unnatural shape, you can insert using a minimal amount of force. This is one of the advantages of DBE.
I think we have gotten close to the splenic flexure now.
Now we have already reached the splenic flexure. We inflate the balloon on the end of the endoscope at the splenic flexure and then advance the overtube. When the tip of the overtube comes close to the splenic flexure, we can consider this point a second starting point. We will now completely straighten the sigmoid colon.
All right, please position the patient in a supine position.
We normally perform a transanal DBE in the supine position. This position allows the stomach to stay flat and makes it easier to make concentric circles inside the small intestine. That's the reason.
All right, let's deflate the balloon on the end of the endoscope and begin the next advancement.
Since the overtube balloon is secured at the splenic flexure, we can naturally enter the transverse colon without putting pressure on the splenic flexure. When you have reached the splenic flexure, you should straighten the sigmoid colon to confirm that the total insertion length of the endoscope to be approximately 45 centimeters.
45センチ程度になることを確認しておく方がよりベターです。
However, with DBE, even if the sigmoid colon is not fully straightened due to adhesion or other reasons, you can continue with insertion of the endoscope. When traversing the large intestine using DBE, some doctors attempt to use the endoscope in the same way as with a colonoscopy, without using the balloon. But it is much more efficient to make use of the balloons and the principles of DBE. Alright, let's try to completely straighten it up for now. Remove any unnecessary loops and completely straighten it out, and then we'll move to the next step. The endoscope will be gently fixed in place with the balloon, which makes it easy to straighten or otherwise simplify the shape. In a normal colonoscopy, the distal end of the endoscope comes out as you pull the shaft. Even in such a situation, the distal end of the endoscope being secured to a certain extent enables you to simplify the shape of the shaft. Thus, if insertion becomes difficult using DBE, you can make adjustments at any time to ensure that the next insertion is easier before you begin it. I consider this the key point in using DBE for colonoscopy. We enter the transverse colon with a slight curve towards the hepatic flexure. DBE makes it easier to pull up the transverse colon. Using both the endoscope balloon and overtube balloon to grip the hepatic flexure and then pulling the shaft allows you to lift the transverse colon to open up the hepatic flexure.
We might have already come as far as the ascending colon. Let's check the location on the fluoroscopic image.
So this is how it is. This is the transverse colon in front of the hepatic flexure. Let's proceed with the image displayed. Here I start to pull. Normally for a colonoscopy, a certain level of technique is required to prevent the endoscope distal end from slipping back. Unless you maintain the balance while pulling it, you can't lift up the transverse colon. Using DBE, the end of the endoscope is secured by the balloon and you don't have to worry about that. When it's like this, in a normal endoscopy, the distal end would slip right back. But here, the shape can be maintained without the end of the endoscope slipping back. If you do that, the hepatic flexure opens up. Therefore, a relatively simple logical insertion is possible without requiring the extremely subtle technique of a colonoscopy. When this happens, as the hepatic flexure becomes a convex arc on top, the endoscope enters the ascending colon in a nearly straight line. Advancing until the cecum is reached while adjusting the shape in this way creates a situation in which the ileocecal valve always appears on the left side, the 9 o'clock position. If you proceed normally, the ileocecal valve will come up on the left. There seems to be a little angulation near the cecum. Even when there are some angulations and you need to form a curve in order to enter, the overtube balloon will grip the ascending colon and assist you in forming a curve. This does not mean that you can force the endoscope to push it into any shape, because the gripping force by the balloon is very gentle. It is best to advance the endoscope by adjusting the shape and use as little insertion force as possible.
Now we are at the opening of the appendix.
And here the ileocecal valve will normally come up on the left. When the ileocecal valve comes up on the left, torque the distal end to the left at a slight upward angle and advance it.
This patient is undergoing testing for Crohn's disease, so we will check whether the shape of the ileocecal valve is normal. We will carefully check whether there is inflammation or ulcers on the ileocecal valve before inserting.
Up to this point, there have been no lesions, have there?
No, there haven't. If it is difficult to enter the ileocecal valve, move a little deeper like this. Torque the endoscope to the left, angle it slightly left and upward with the dials. Pull a little, and the opening will become visible. When you look for the opening, it will be easier to locate the lumen if you hold down the water supply button and supply water.
This EN580T endoscope enables a close observation of 2 millimeters, so the advantage is the ability to get a relatively clear image during this procedure.
Next, once the end of the endoscope is inserted, try as much as possible to straighten the endoscope. If you insert without straightening the endoscope retroflexes into the cecum like this.
If you push the endoscope in a fully bent position, the force will be transferred so that the endoscope distal end moves back to the cecum. In order to advance the endoscope deeper, you must enter the ileocecal valve and straighten the endoscope again before you advance forward.
In this patient, the endoscope insertion is not easy, so I will inflate the balloon on the end of the endoscope, advance the overtube closer to the ileocecal valve, and try again.
Let us go closer. This patient has an angulation near the cecum as we discussed before. With such angulations, it seems difficult to apply force in a straighter direction.
Yes, I agree. Let me see the shape of the fluoroscopic image, please. Show me the lower part. Move the hand.
It's a little angulated right here, isn't it?
Yes, it is. His cecum is angulated inward here. I will inflate both the balloons and pull back. Then the position of the ileocecal valve changes slightly and the insertion becomes a little easier.
So it faces a straighter direction. If we see the endoscope image, the ileocecal valve will face toward us.
Yes. Now I will deflate the balloon on the end of the endoscope and try to enter the ileocecal valve again.
You're trying to insert in a straighter line, right? And he will use water instead of gas. He will not push in, but instead advance the endoscope slowly. This will make it easier to straighten the endoscope distal end again. Then we will advance the endoscope further by jiggling to the right and left without forcefully inserting the shaft. Advancing as much as 3 or 5 centimeters at this point will make it easier to transfer the insertion force applied to the shaft to the distal end of the endoscope. If the distal end keeps slipping out of the ileocecal valve, techniques like abdominal pressure, using a stiffener, or changing patient position may be helpful. Do you want to try?
Let me take a look at the fluoroscopic image.
Right here, the endoscope is bent. Here, you can push like this. This here, right? Okay, we don't need the fluoroscopic image anymore. Ultimately, if the endoscope does not retroflex out into the cecum, you can advance the distal end forward. Let me look at the fluoroscopic image again for a minute. Once the endoscope distal end is straightened up, you can advance it even deeper. Insertion is difficult when the force applied from the shaft to the end of the endoscope is not transmitted in the correct direction. If you find a way to transmit it in the correct direction, you can successfully navigate difficult areas.
We have now inserted 15 centimeters in from the ileocecal valve. So at this point, we inflate the balloon on the end of the endoscope and advance the overtube.
The overtube has reached the ileum. For the first insertion, you don't have to worry too much about shortening. Just focus on adjusting the shape. If you pull the overtube back too much, it will come out of the IC valve into the cecum. The overtube balloon is inflated as we begin the second endoscope advancement. Never push it forcefully. Pushing folds aside, use the slalom technique to advance the endoscope end as straight as possible. Even for cases that require you to form an angulation, avoid letting the endoscope angle fully bend. Once the endoscope begins to advance, try to straighten it out wherever possible and jiggle the endoscope and suction gas as you move while using as little insertion force as possible. This holds for standard patients as well, but for Crohn's patients in particular, the location you arrive at immediately after entering the ileum consists of complicated tangles of bowel sunken in the pelvis. The first thing you need to have in mind is adjusting the shape of the endoscope without forcefully pushing in.
Let's advance the overtube again. This is a 5 centimeter insertion.
Even if you try to push it in, it will not go in easily. Did we use an anticholinergic agent earlier?
Would you add some more now?
Another dose intravenous. We administered half an ampule before, didn't we? So we used the remaining half. Oh, did we? Then use the other one. And Dr. Yano, let's use peppermint water if we need it.
Ah, yes, we will use peppermint water.
Well, the villi look very clear, don't they?
Yes, they do.
Judging by this, there are no lesions in the areas reachable in a normal colonoscopy,
No, there aren't.
which means that this could not be diagnosed with a normal colonoscopy.
The angulation of the small intestine in the pelvis is making it a little difficult to advance, so I will change the patient's position. Move the patient to the left lateral position.
When insertion is difficult, in most cases, the distal end of the endoscope is fully bent. By changing the position of the patient, it is sometimes possible to change the angle of the bend from an acute angle to an obtuse angle. Doing so may help insertion. And once you have passed the difficult areas, it will be easier for you to simplify the shape. So when you are working in a slightly difficult area, be patient and try to advance carefully. If you could advance even little by little, you will be able to adjust the shape of the intestinal tract in the next step. Particularly in the case of insertion from anal approach, immediately after entering the ileum, try to advance slowly in small steps. Actually, it's beginning to advance nicely now. When the endoscope is advanced in a good shape like this, even if complete concentric circles are not formed, you can adjust the circles by pulling on the endoscope in the next step.
Okay, let's position the patient in the supine position. Let's see the fluoroscopic image.
It's important to adjust the shape before you begin the next advancement.
For reference, I will show you the shape on fluoroscopic image.
It looks like the distal end of the endoscope. Oh yes, it's forming a nice concentric circle. It's ideal to form this kind of concentric circle. And when it does, you're able to gently advance the overtube. Here, the balloon on the end of the endoscope grips the intestine to prevent the endoscope from slipping out.
15 centimeters.
I showed you this action on the fluoroscopic image as well, but we usually perform it without using fluoroscopy.
As you shorten, try to create a shape that enables you to return the angle to almost a straight line with the lumen visible in the field of view. As you torque to the right and left like this, if the screen responds to the torquing immediately, you will know that you have removed unnecessary loops.
Removing unnecessary loops and maintaining a natural and simple shape makes the next insertion easier. Let's try to show this on fluoroscopic image. Well, this is the shape we are working with. It is significantly shortened. Okay, that's good. Okay, then we will not need fluoroscopy for the next insertion. With Crohn's disease, there are sometimes no lesions that can be identified within the range reachable by colonoscopy. Some patients have lesions that can only be seen deep inside the small intestine. For such patients, an early diagnosis is only possible with enteroscopes. As you can see from this, you can't just push the shaft of the endoscope in, but rather use the minimal insertion force required to control the endoscope end effectively. Keeping that in mind, the endoscope end will advance through the intestinal lumen in a nice glide. And that's good for advancement because only the minimum force is used to achieve the result.
Right now, the tip of the endoscope is facing the opposite direction. So if we check it with fluoroscopy, the end of the endoscope would likely be facing outward instead of toward the center of the concentric circles. This is how it looks.
So you'll know how it may look even if you don't use fluoroscopy. Given your own posture and patient position, the direction of the endoscope tip is determined. If you entered facing the left, the up dial of the endoscope tip makes the concentric circles. If you are facing the opposite direction, it means that the endoscope tip is also facing the opposite direction.
Forcibly pushing it in this situation would only make it difficult, so you should advance the overtube and shorten it first, meaning you adjust the shape before the next advancement.
So while shortening, you can recover the concentric circle shape again. You can perform this action without the endoscope slipping back to an excessive degree because it is secured by the balloon. Even if you see on the monitor that it is slightly sliding or coming out, do not worry. It is much more important to adjust the shape. Adjusting into a simple shape enables an efficient advancement and will compensate for the small distance lost by the endoscope slipping back.
The last insertion length was 20 centimeters, so let's begin the next insertion.
If you adjust the shape in this way, what seemed like an awfully difficult insertion will become easier. The bends of the small intestine are natural angulations, so it's efficient to insert the endoscope with an easy shape after adjusting the shape, rather than forcefully pushing it in. If you maintain this shape, you simply need to repeat the same operation. You'll be able to continue to utilize the angulations inside the abdominal cavity that will be advantageous for the insertion of the endoscope.
When doing so, if you stand in the same position without moving your feet, you will be able to draw your hands to the optimum position without viewing the fluoroscopic image.
It's best to find a natural curve inside the abdominal cavity because once you find it, you'll be able to use the same curve again and again. When you use this method of insertion, which is most often used for bowel inspection, in most cases the 11 o'clock position will be the mesenteric side and the 5 to 6 o'clock position will be the anti-mesenteric side. It sometimes changes due to the angulations during advancement of the endoscope, but basically the intestinal tract should be adjusted in such a way before further advancement. We always attach a hood on the distal end of the endoscope. In the case of diagnostic procedures, we use a very short hood that juts out only 1 millimeter from the endoscope tip, and so it is barely seen on the monitor. However, this hood allows a clear view of the lumen without mucosal readout. Therefore, it is easy to ascertain the direction of the lumen. By using the hood and water supply, gas can be limited to a minimum amount. Today, Dr. Yano has insufflated almost no CO2. In this way, he can find the next lumen and advance the endoscope with minimal insertion force.
Let me see the shape on the fluoroscopic image, please. Alright, insert the overtube.
The endoscope's very bent, isn't it?
If we proceed with no insufflation, you can see on the fluoroscopic image that there is almost no gas left inside the intestine. Move the hand. If there is no gas in the intestine proximal to the overtube balloon, the shortening can be effectively conducted. If there is gas, it may be an obstacle during shortening.
With little gas, the small intestine can really be shortened efficiently, can't it?
Yes, that is so.
Then let's adjust the shape so that it will be easier for the next insertion. We repeat this action to advance the endoscope deeper and deeper. Do you think the ileum fixed by the mesentery is a problem here?
Is it turning up? Okay, advance the overtube one more time. In cases like this, when pulling back does not help, perform the next advancement without pulling back.
That would mean changing the part of the curve in the abdominal cavity you are using. Right now you are using the curve at the left side of the abdominal cavity, but you are going to use a slightly different location inside the abdominal cavity, a different part of the curve, for advancement. In other words, this would mean advancing the endoscope without pulling back the overtube. Show me the fluoroscopic image for a minute, please. A little more to the left. Okay, let's try to go in here for now.
I didn't shorten just now.
It's a slightly tight angulation right there, isn't it?
This isn't very easy, is it? In cases like this, change the position of the patient. Can we move the patient to face the other side? In difficult situations, it's better not to overdo the same approach without advancement of the endoscope, as it may cause complications.
This is a difficult call to make, but you certainly don't want to overdo it.
At the same time, you also cannot give up too early.
Yes, giving up too quickly could mean stopping just before reaching a lesion.
Trying with slightly changed conditions or approaches may lead to a breakthrough in a difficult situation. Please show me the fluoroscopic image. This is a situation in which the sharp bending of the endoscope tip is inevitable, but we want to try to do enough shortening to straighten the endoscope tip. But it's going to be a bit difficult. Let me see the fluoroscopic image again. Okay, please go ahead. There is still a bit of deflection, but I will try to insert one more time while trying to straighten it out as much as possible. When doing this, it will be easier if you insert the scope while slightly jiggling it, rather than just pushing it.
It's just started going in.
I got past it. Please add some pethidine hydrochloride.
It looks like we made it past the angulation all right. Once you get past a difficult area, in many cases you are able to get it into a good shape.
All right, let me see the fluoroscopic image, please.
Ultimately, we were able to return it to a concentric circle shape. The good thing about DBE is, as you can see here, when you advance the overtube, in most cases the end of the endoscope does not slip back. The balloon attached to the end of the endoscope increases stability. Since one of the two balloons is inflated at all times, when the overtube is advanced, the stability of the endoscope is maintained by the inflated endoscope balloon. The balloon on the end of the endoscope can grip the intestine, so the overtube can be advanced, keeping the intestine shortened. A very efficient procedure.
30 centimeters? Okay.
Right now, while the overtube was being inserted, it went in smoothly without the distal end of the endoscope coming out. Even if it seems likely to slip back a little, keep your focus on adjusting the shape. Both the endoscope balloon and overtube balloon are securing the intestine, which means that the maximum retention force is applied now. Now the overtube balloon retains the intestine and the balloon on the end of the endoscope is deflated and the endoscope advances.
Well, in the case of this patient, I don't think there is any reason to go any further than this. So we will end with this insertion today. Please give me a marking clip. Here you are. Contrast agent, please.
Judging by the contrast pattern, stenotic lesions are to a certain degree seen over a slightly longer area. I explained earlier the reason why we are placing two clips in a row here, but Dr. Yano, would you explain again?
If we use one clip, we don't know whether that clip is solidly fixed to the intestine. But if we place two clips, and those two clips are visible side by side in the X-ray, we know that they have stayed where we intended. That is the reason why we place two clips. Okay, now the contrast media is going in. Please take one image. Fluoroscopy. Please take an image. There are no particular findings on the image that suggest longitudinal ulcers or stenosis.
Even if we want to perform endoscopy of the entire small intestine, we are not forcing ourselves to try to see it all in one procedure. Usually the insertion efficiency is reduced when inserting 4 meters or longer from either direction. So when the endoscope can be inserted at that level, doing so from the opposite direction allows you to reach the mark easily without wasted effort. Sometimes it just happens, but we do not make a goal of seeing the entire small intestine on one pass.
Okay, please take one image.
There does not appear to be any significant stenosis, does there?
We just have to check whether there are any erosions or ulcers in the lower ileum on withdrawal of the endoscope.
Yes, we do, where we make sure there is enough insufflation during inspection on withdrawal.
We should inspect carefully because there is a possibility that we are seeing a very early stage of Crohn's disease.
The biggest advantage of using CO2 insufflation is that even if sufficient insufflation is performed during inspection, CO2 is quickly absorbed after the examination, resulting in less discomfort with fullness or pain for the patient, and it's much advantageous in case of complications such as perforation. With air insufflation, in the event of a perforation, air immediately leaks into the abdominal cavity and there would be no time to close the perforation with clips. But since absorption of CO2 leaked into the abdominal cavity is much faster than air, we can have enough time for endoscopic closure with clips when CO2 insufflation is used. During the inspection phase, if the overtube is withdrawn over the entire length, the intestine pleated on the overtube will rapidly uncoil and lose its manipulability. That is why we move back the overtube by 10 centimeters at a time to allow controlled release of intestine for inspection. Because on each 10 centimeter length of overtube, about 30 centimeters of intestine is pleated. Until the white line on the endoscope appears, we continue to pull the endoscope back from the overtube to inspect the mucosa, but the assistant must be holding it to ensure the overtube does not come out as the endoscopist withdraws the endoscope. Otherwise, it could result in excessive shortening and cause bowel intussusception. Up to the point that the white line appears, we're already at the end. This is the ileocecal valve.
There was nothing there.
That was a negative study, wasn't it?